Hi, my name is Jason, and I'm showing you my PowerPoint presentation about a composite preparation and restoration that I did on tooth number 21. Let's talk about the background. The patient came into the first aid clinic because her front tooth, number 21, part of the filling chipped off. When I just talked with her, I found out she's 45, she's a mother too, healthy, no significant medical history. She was at the corporate clinic a month ago, and she knew that she had to get that front anterior tooth, had to get some treatment. She knew she had to possibly get a new crown, but today she explained to me she did not want to leave the clinic unless she had something that she could walk away and be comfortable with because it was so unesthetic. So here's a quick picture of what we were starting with. I told the patient I could just add some composite to the missing areas, but I wanted to replace the entire restoration, which went down to the gingival margin on the facial side. Again, I showed you another picture of the same tooth with red arrows, emphasizing where I'm talking about where I could add some restoration, but this was not the decision I made with her today. On this slide with the yellow arrows, you can clearly see that the contralateral tooth, which basically means the tooth right next to it, we can see that this also had a composite restoration. We see exactly where the gingival margin is. So now we have a guideline as to what the goal is for what we're doing today. So the first thing I thought to myself is I've seen a lot of YouTube videos, and what they like to do is they start with a silicone key. So let me put some composite on the palatal side. I'll light cure it really quick, and I can get started making a silicone key. We use this orange putty by Elite, orange-white putty, to make a silicone key. Here in this next slide, we see a silicone key that I made. So on this slide, this is basically the finished preparation. I try to use wedges to try and move things around to push the teeth aside so I won't hit the adjacent tooth. And now we're going to talk about the errors I see in this preparation. First error that I see is on the mesial side. I put a little red arrow by there. There's a hole, and you'll see in this next slide, the arrow really points to the size of that big hole. The second error that I see is that the old composite wasn't removed. Um, Now, the thing of my thought process is that I'm afraid I'm going to get a little nub of a tooth if I remove all of it. Is there caries under there? Probably unlikely. She said she broke it up. She broke the tooth recently, which makes sense because when a patient has a tooth like that, female, they're not going to wait around for caries to develop before they actually start uh, before they get treatment. So I think that maybe it was the right decision, but probably not. But do I want to risk a pulp exposure today? I'm sorry, but I don't. I don't know if that's the right decision. I don't think it. Maybe it is. Maybe I'm not. But I'd love to hear your feedback on that. The next error that I saw was I had poor isolation using the rubber dam. The rubber dam just keeps creeping up, and it's just such a pain. I know about floss ligatures, putting little floss around it, but I tried to get my assistant to help me, and she couldn't follow me, and I need her help to do this. And the amount of time we've taken, it was just very difficult. So when I asked her for help, she ended up giving me a retraction cord. Um, there's just a lot of pressure to move fast where I am, and so I didn't feel comfortable, but I did the best I could. I think next time I will insist on using the floss. Here's a video that I remember that teaches us how to place floss ligatures on the rubber dam. Here's another view of my preparation. As you can see, the wedge is darn stable. It's just very difficult here for me. So here's a close-up of my preparation. We see that on the wedge side, the distal side, there's that little valley that I should have cleaned out. There's composite still left over. And on the mesial side, I guess you call that unsupported enamel, but honestly, it reminds me of a class 3 on the gingival wall. So I'd love to hear your feedback if this is what should be there or should not be there. And if it should not be there, how should it look? You tell me. Here is another view of my preparation. Now, at this point, I'm rushing a lot. I didn't have time to show you how I built my restoration, but this gives you an idea. I used a Tafelmauer matrix. I cut it because I find that the clear plastic ones, they always end up falling out of the patient's mouth. The rubber dam pushes it aside. I try to put in a wedge. The wedge pushes it and it falls out. I just find it so difficult to use, so I take a Tafelmeier matrix and I worry about getting the correct contour later. This is not the best way to do it. I know it's not the best way to do it, but it's the best system that I have at the moment. And as you can see, I wrote the words rush, rush because I already had patients waiting outside and I still want to do a good job, but it's very difficult when my assistant's telling me to move faster. The purpose of this slide is to show you my difficulty in getting getting the contact points on class 4s or sometimes class 3s. So I put the Tafelmeier matrix in and I build in layers up to basically where I think the contact point should be. Now the wedge doesn't really help me make that contact. So what I do is I take my Explorer, which I put in red, and I push really hard, in this case distally, and I apply force towards the distal, and then I ask my assistant to put light on, and then later on I come in and I put some put composite into that little area that my Explorer just created. So in this slide, this is after I did all my light curing. I don't like it. It looks rushed. I made the entire anterior composite in one layer because I know if I build in layers, it means at the junction of the new and the old composite, there would be areas that wouldn't be smooth, little lines, wrinkles as I call them, and it's very hard to get rid of them. I like to overbuild the composite because obviously once I start cutting it down, it's very, very hard to add composite if you take off too much. Here's another view of my restoration and a incisal view on the next slide and another incisal view on this slide. And now we are up to the final restoration. So this was a lot of work with my burr, but the patient was super happy with it. It took me about 75 minutes from start to finish. I had to put on the rubber dam twice, stopping because of anesthesia issues, and I lost a lot of time because I had to find equipment, and the assistant didn't understand what I was saying because this was definitely her first time doing something of this magnitude. On this slide, we see that it is very wide compared to the adjacent tooth. We also see that the gingival margin of the 11 is much higher than the 21, which means that it can kind of also throw off our eye a little bit in terms of the width. But I made sure to have contacts between the central and the lateral, whereas if you saw in the initial photos, we'll see later on that there's kind of like little gaps between the teeth. Here is an incisal view of my work and another incisal view, another view from the side, and finally the final restoration. I used Dentsply Enhance silicone finishing burrs, which I really like, and I also bought some burrs off of eBay that shine. I don't like the Soflex discs because it takes me just too long to take on and take off the discs, and many times the assistant has to go running from room to room looking for them. So I splurged $5 on these shining burrs from eBay. So here's a before and after slide of where we are. Again, I want to emphasize that the patient was very happy. I think she knew inside that I was not fully happy with it, but she was just so ecstatic and she was uh, very gracious, let's put it that way. So this next slide talks about my thoughts. Management. I had very poor time management. I've seen on YouTube, I've spoken to many people who do these type of things, and it usually takes them about an hour per tooth. That's including a well-trained assistant, and obviously knowing where materials are, and you've using materials and equipment that you've used more than once. So for me, it was my first time trying to do, let's say, floss ligatures. The second point about management that I want to say is that I have a poor presentation for you guys here. Um, I should have taken a picture of the X-ray with my iPhone. I didn't do that. I also should have maybe taken a picture of the medical treatment record so you can see that there was actually an indication to do this composite veneer. Also, recently my iPhone got some kind of virus and it's very hard to control it. Sometimes it won't wake up or the focus gets messed up. But either way, it's still a poor presentation. And it's also my first presentation that I'm doing for you guys on PowerPoint ever. Now, my second thought is about the preparation. On a 1 to 10, where 6 is passing, I give myself a 4. We discussed the errors, not removing all the composite, having that little bubble area that wasn't good. It might have ended up in a root canal, but if there's caries on the composite, it doesn't make a difference. If it could have ended in root canal, it could end up in root canal. But the point is, I think I should have done a better preparation. I also probably should have placed calcium hydroxide or Vitrabon because I was so deep into the tooth. So now let's talk about the restoration. I typed into Google some type of an evaluation form for a dental restoration. This is what came up. So when we talk about the color of the restoration, I want to use a variety of colors, but in the corporate clinic that I work at, we only have basically A2, A3, and we have some Dentin shade color. So I can't use white staining and all that stuff, which I'd love to do, but maybe if you guys have a recommendation where I can buy some cheap through eBay, that'd be great. Second, there was no marginal staining. Everything was smooth and shiny. I think it was good enough. Marginal adaptation, fine. Anatomic form. You'll see they took a little bit off the mesial facial line angle. Could have had some more, but it wasn't critical. My eye will notice it. Your eye will notice it. The patient less likely to notice that. The height, obviously we know it looks short and fat, but again, maybe that's because of the location of the gingival margin of the adjacent tooth. Now I want to talk about some troubleshooting. I didn't see this coming. It was a first aid situation, and if I knew it was coming, I probably would have reviewed some YouTube videos, walked around the clinic to make sure we have the type of materials, and I probably would have brought some of my some of my equipment I have at home. I have some brushes and other equipment, but like I said, I didn't see this coming. I also want to say that I used way too much flow because I find that the composite just keeps sticking to my equipment, and the way that I get around that also is that I use a micro brush. I also had some photography issues. Like I said, my phone has a little virus, and maybe I should buy some cheap lenses off of eBay so that way I can get a better focus also, which would help. And the fifth troubleshooting problem is dealing with my assistant. Obviously, I'm not in control of her salary, and she has no incentive to work hard. When the patient sat down, I'm sure my assistant expected me just to add some composite to the corners, and so that way for the next hour, because we had an hour cancellation, um, she could, work for 10 minutes and then go drink coffee for 50 minutes. And I saw this for me an opportunity to advance myself professionally, so I took it upon myself to do this, even though I'm sure my assistant was not too thrilled about that. Here's a picture of some Facebook research that I saw, and I was impressed with this clamp. That's a 212 clamp, I believe. If I'm wrong, please correct me. I don't know if we have this in the clinic. We probably do, but it would take a very long time for my assistant to find it, and I'm sure my assistant doesn't know the words 212 clamp, so it'd be problematic likely. Also in this picture, the dentist used a sectional matrix. I know what they're talking about. You take a Garrison or a Powdent matrix and you, instead of going buccolingually, you hold it occlusal gingivally, and from there you can make your wall. When I do that, I have two issues. One, the sectional matrix falls out, and two, I don't necessarily get that good strong contact. And from where I studied, it's very important to get that good strong, snap of the floss contact. So now here are some favorite YouTube videos that I saw for anterior restorations. This is a link that you guys can check out later. I really like her. Um, Katya. These other videos are basically what I meant when I'd say I do my research and homework before if I knew had a patient coming in. Anyways, here we are at the end. I'm very happy to get your feedback. Again, the purpose of this video is to show you my errors so I can improve myself and advance myself professionally. I've taken private lessons from dentists on how to do anterior composite restorations, but clearly it didn't help as much as I thought it would. Please leave messages, send me feedback, send me private messages, and if anyone's out there who would love to be my mentor, I'm very happy to hear from you. Thank you again. Bye bye.